Welcome to Chapter 14, Principles of Assessment, Emergency Care, 14th edition for the EMT. So, patient history. So, there's two different components. So, there's the history of the present illness. So, basically, what's going on with the patient right now. And then there's past medical history, which is the history of the patient. That includes, significant or things that are needed to know for the patient about their history, their medical history. So techniques. History is obtained by talking to the patient. If the patient's unable to respond or they don't know their history, then family members, bystanders, medications, and anything that you observe at the scene, like insulin syringes or drug paraphernalia or medications or various other things. Okay, so develop a rapport with the patient. Say, hey, this is me. I'm with such and such ambulance, and I'm here to, take care of you. Ask open-ended questions. So those open-ended questions are, how are you feeling today? What does it feel like? How bad is the difficulty breathing? Ask those questions instead of, are you having difficulty breathing? Does it feel like chest pain? Does it feel like a stabbing pain? Those things. And only use those closed-ended questions if you need an immediate answer. History taking helps you obtain a picture of what is going on with the patient. OPQRST. This is to learn about the chief complaint and the history of the present illness and injury. Typically, this only really works for pain and difficulty breathing. So onset, provocation, quality, region, radiation, and severity and time. When we talk about onset, when did this start? Is it consistent? When did this start? Okay. Provocation, does anything make it better or worse? Quality, what does it feel like? Is it sharp, stabbing, dull, achy, pressure, those type of things. Region, where is it and does it go anywhere? So chest pain, does it go up into the left arm? Does it, if they've got abdominal pain, does the abdominal pain go somewhere else? Because it can be you can have referred pain or radiated pain. There's two different things. So referred pain is pain that is affecting somewhere else. So like the abdomen. You could have shoulder pain with appendicitis or gallbladder issues or something like that. So it just kind of depends where you're at in the abdomen. And then severity. Not that I'm a fan of it, but it does help kind of gauge where your patient's baseline is, and then you can further investigate after you've done something to help them figure out if it's gone down or gotten worse. So that scale of 1 to 10. And then time. Is it consistent? Is it all the time pain? Is it intermittent pain? That type of thing. Sample. Samples used to learn about the patient's past medical history. It includes signs and symptoms, allergies, medications, pertinent past history. When I talk about pertinent past history, I want to know basically 5 things that are really important to me at the time, which is heart problems, breathing problems, seizures, diabetes, or strokes. Those are the 5 things that I really, really need to know. And then past that, I can kind of dive into, some more specific things like any recent surgeries or, if they have abdominal pain, do they have all of their organs? Those type of things. What their last oral intake is. Last oral intake is kind of important because I want to know if they're going to aspirate anytime soon, or if they're going to go to surgery, they need to know when they last ate or drank anything. And then any kind of events leading up to the injury or illness. What were they doing beforehand? Were they walking? Okay. If they were walking, maybe they're having difficulty breathing. So what were they doing before the difficulty breathing started? Were they walking? Did they have some type of exertion? Were they running? Were they doing something that would cause, the heart rate or the respiratory rate to increase? Or were they just sitting there? If they were just sitting there and the difficulty breathing started, maybe this is a more serious thing. When assessing children, preschoolers can be interviewed with simple language. School-age children will be able to describe what they feel and what happened. You want to include the parents, teachers, and or care providers in your interview as well. Yeah. Physical exam techniques. So this is performed before, during, and after the patient history. There are 3 primary techniques we're going to observe. We're going to look at the overall patient condition. Auscultate, we're going to listen for abnormal conditions in the lungs or heart. And then we're going to palpate, feel an area for deformities or other abnormal findings. The pediatric physical exam approach frightened children slowly. Start from the least invasive parts to the most invasive, so like toes to head. So a toe to head physical exam is probably best with pediatric kids versus a head to toe that we do for adults. Explain all the equipment to the child before use. Never lie to a child about something that may hurt, and provide the patient with privacy. So specific body system exams. So most important determination when assessing the respiratory system is whether the patient is breathing adequately. And then we're going to look at lungs and the airway to figure that out. In our history, we're going to obtain a history of existing respiratory conditions, COPD, CHF, asthma, anything like that, and determine if any kind of medications have been taken as prescribed, and determine if signs and symptoms of the episode match previous episodes. So if you've got a patient with difficulty breathing and you ask them, hey, does this feel like it has in previous times where you've gone to the hospital? And they say yes, then hey, that's probably what we've got going on. Or they say no, this is different, then we've got to do a little bit more investigating. We want to assess their mental status, their level of respiratory distress, chest wall motion. We want to auscultate their lung sounds, use pulse oximetry, and observe for any edema. Edema in the lower limbs would indicate that the patient probably has some type of failure, heart failure, and they may have some pulmonary edema as well. And then fevers. The cardiovascular system includes the heart, the blood vessels, and the cardiac patient or patient in shock, or a patient with vascular problem. History, so existing cardiac conditions, so CHF is one of those things. Any previous heart attacks, any kind of heart conditions, do they have a pacemaker, do they have a defibrillator? All of those things are good questions to ask. You want to know what the signs and symptoms of this episode are and compare them to previous episodes if they've had previous episodes. And then you want to get a description of the chest pain using that OPQRST mnemonic, and then determine any kind of specific characteristics of discomfort. In our physical exam, we're going to look for any kinds of signs that the condition may be severe. So pale, cool, clammy skin is like textbook heart attack. Okay, they may be diaphoretic. They may be circling the drain. They may look like they are just absolutely sick, and yeah. Obtain a pulse, blood pressure. Note the pulse pressure. So pulse pressures are different. Pulse pressures are your systolic minus your diastolic, and that gives you a pulse pressure. A narrowing pulse pressure would indicate something that basically is like trauma to the heart, or something like that. JVD. JVD is a late sign of anything. It's hardly ever seen in the EMS realm. And if we do see it, you're late to the ball game and you got to get going. But JVD is one of those things that it can happen. Very rare that it does, that we see it. Palpate the chest and observe for posturing and breathing. The nervous system, so any kind of mental status or signs of dysfunction in the body. Okay, assess mental status, determine the normal state and functioning of the patient. So you've got to determine what their baseline is before anything else. So if the patient's baseline is that they are alert to person but not place or time, then that's normal for them and that's absolutely okay. If your patient is has acute mental status changes, then I want to know what's normal and what has changed now. And then obtain a history of neurologic conditions such as seizures, seizures or stroke, or anything like that, and then note the patient's speech. In our physical exam, we're going to perform a stroke scale. Stroke scales we'll talk about later, but stroke scales kind of determine whether or not the patient is having a stroke. You see the commercials for the FAST exam, so face, arm drift, speech, and time is the FAST exam. Peripheral sensation and movement. So can they feel me touching them? Can they move their arms? Do they have purposeful movement when they move their arms? Okay. Gently palpate the spine. Check for extremity strength. Check the pupils for equality and reactivity, and examine the patient's gait or how they walk. Okay. Do they walk with a limp? Do they put more pressure on one side than the other? Do they do they bend their knee? Do they not bend their knee? Those type of things. The endocrine system. So the most common endocrine emergency is a diabetic patient. So history, diabetes mellitus or thyroid disease, current medications and whether they're being taken properly. So like insulin is one of those things that is typically not taken properly. They may be on a sliding scale. They may be on a fixed dose. So we need to know that. We need to know when they last took their medicine, if they're compliant or not compliant. Okay. Whether the patient has eaten or exerted energy at an unusual level, and whether the patient is sick. Sickness in diabetics can cause their blood sugars to either elevate or lower. It just kind of depends on the patient and their tracking and their use of insulin or medications. And whether the patient has taken their blood glucose or uses an insulin pump. Insulin pumps are attached to the body through a tube, and it basically feeds insulin into the body. So physical exam, we're going to assess the patient's mental status, observe their patient's skin, blood glucose level, check for an insulin pump, and check for medical jewelry. GI system, so we're looking for what has gone in, what's come out, and what it looks like when it comes out. History, we're going to look at pain or discomfort, use that OPQRST for pain. What was their last oral intake, or what is their oral intake in general. History of gastrointestinal issues, so like Crohn's disease or gallbladder issues. Those things are, or pancreatitis, those things are things that patients live with on a daily basis, and they have to be careful of what they eat, because if they aren't careful of what they eat or take in, then it can cause issues with their GI system. And then vomiting, I want to know, various things like, is it chunky? Does it have a red color to it? Is it dark? Coffee ground type vomit? in their bowel movements. I want to know if it is it bright red or is it like a dark tarry color, and consistency. Those things all clue me into GI problems that the patient could be having. Physical exam, observe the patient's position, assess the abdomen, and inspect other parts of the body, inspect other parts of the GI system, and inspect vomitus or feces if available. Do I really want to look at it? No. Do I need to look at it? Kind of, yes. Only because I need to know if it is that bright red, dark red type color. Yeah. The immune system. So the most relevant immune system problem is anaphylaxis or an allergic reaction for EMS. I want to know what their history of allergies is. So I want to know if they were exposed to a known allergy like peanuts or latex or something like that, and what their typical reactions are. Does the patient have a history of asthma? Do they have any kind of symptoms of tightness in the chest or throat? Any kind of GI distress, nausea, vomiting, diarrhea, that type of thing? Itchiness or rash? And then do they take any kind of medications for an allergic reaction, such as an EpiPen? Okay, physical exam. So I want to inspect the point of contact with the allergen. Do they have rash or hives on the skin? Is it localized or is it systemic? If it's localized, it's only going to be in the area where contact was made. I personally have an allergic reaction to cats. No, it's getting better. We have 4 cats at home, but it's gotten better over the years. And I typically don't get any kind of reaction if I pet the cats. But then if I play with the cats, then I'll get some whelps or hives on my arms where I was playing with them. And I just have to be careful because if I am playing with them for a while and I don't wash my hands and then I go to touch my eye or something like that, then my eyes will start to water and I'll have to take out my contacts and be blind for like a week because my eyes are just so puffy and red. So just look for those things. And then those are all localized symptoms. Systemically, you can look for hives and rash in areas where there wasn't point of contact. Typically, it's going to be on the chest, the abdomen, the neck, the face. Those things are going to have hives or rash, and that means that it's a systemic type of allergic reaction. We're going to inspect the face, lips, and mouth for swelling. Listen to the patient speak, and listen to lung sounds for adequate breathing. Musculoskeletal system. So medical diseases in this system are rare. Typically, when we do any kind of exam or history or anything like that, it's going to be a trauma type exam. So we're going to look at any kind of prior injuries. We do want to know if the patient is taking any kind of blood thinning medication because there's a lot of blood in the bones, and if they're taking a blood thinner, then the patient could bleed out more easily. We want to look at any kind of underlying conditions or diseases that make fractures more common, so like osteoporosis, those type of things. History to determine if a medical problem caused the traumatic injury. So maybe they fell and they broke a hip. Okay, why did they fall? Did they trip, or were they dizzy, lightheaded? Did they pass out? Have a syncopal episode before they fell? Those are the things that we need to know. On our physical exam, we're going to inspect for signs of injury, such as deformity. We're going to palpate areas with suspected injury, compare sides for symmetry, be alert for crepitation. Crepitation is when you have bone rubbing against bone. Typically, it's because something is broken in there or mushed in there, and you've got a lot of little bone pieces. It's a very chilling feeling when you feel crepitation and hear it, because it's like, for me, it's like nails on a chalkboard. Assess the patient head to toe, and if there are multiple injuries or if the patient is unresponsive. Critical thinking and diagnosis. Diagnosis is a label for condition based on history, physical exam, vital signs, involves both physical and intellectual activity. We diagnose. You as an EMT diagnose. Okay. Your diagnosis may have several things into it, such as a differential diagnosis, but you diagnose because you're going to treat your patient based on what you think is wrong with that patient. You're going to treat your chest pain patient like an MI. You're going to treat your respiratory patient like they have some type of respiratory problem. You're going to treat your diabetic patient based on your diagnosis of hypoglycemia or hyperglycemia. You're going to treat your allergic reaction, anaphylaxis, okay, based on a diagnosis that they have, that they are in anaphylactic shock, okay? So how does a clinician reach a diagnosis? So clinicians have different levels of training, experience, time, technology, and other resources, and techniques vary among types of clinicians, okay? You as EMTs, you guys have pulse ox, you guys have blood pressure, you have all the vital signs, plus you have a physical exam and history exam. So all of those things go into your diagnosis as an EMT. I have a little bit more leeway, and I have a little bit more tools available to me to make a diagnosis. So like in a heart problem, I have the diagnosis that I can put them on the heart monitor and look at what their rhythm is doing. Determine if they're having a STEMI, so determine if they're having an ST elevated myocardial infarction or a heart attack. There's other options out there. We don't necessarily have ultrasound, but some services do have ultrasound. LakeWest has ultrasound. So they can take that ultrasound and place it on the heart and determine if there's any kind of heart activity. They can place it on the abdomen and see if there's any kind of blood in the abdomen, or if they've got an enlarged liver, or various things like that. I mean, and then in the hospital they have the option to for like everything, CT scan, MRI. They can draw blood work and do labs. It just kind of depends on what's available to them. And every clinician and every provider has their own way of doing things. I don't do it like the next paramedic, but my way is not any less effective than their way. Yeah, there's some tips and tricks and things that I can teach you, but once you start doing your assessments, you're going to be able to get into a rhythm and figure out what works for you and what doesn't work for you. And every single patient is going to be different as well. So you may have to tailor an assessment based on what the patient is presenting like, or talking to them, or talking to family. Okay. So the traditional approach to diagnose in medicine is to assess the patient. Then you get a list of conditions or diagnoses, which is called your differential diagnosis. And then further evaluation to exclude unlikely conditions, and then you come to a final diagnosis. In emergency medicine, we are a little bit pressed for time because sometimes we have to make a diagnosis pretty rapidly. So you're quickly rule out or treat immediate life threats. So those ABCs. And then we're going to gather information from patient or family and friends, perform a physical exam, and focus on ruling out worst case scenarios. Red flags suggest serious problems and may be responsible for multiple patients. Okay. The EMS approach to diagnosis must be very efficient and because we have to be available for another call as soon as possible. Work in an uncontrolled environment. We have a limited tools and skill set, and we have narrowed educational focus. We focus on the EMS. We focus on emergency medicine. We don't have the background of, other things. Now, the more you do this, the more you're going to have background on other things, such as surgery, and you're going to learn about those things. You're going to learn about different diseases and what those do to the body and how that affects the body and various things like that. I don't know everything about medicine. There's still some things that I don't know, but I have a base knowledge of how the body works and the anatomy of the body, so I can kind of figure out what is going on if they kind of give me a like preamble, short little summary of what it does. Okay, we're going to follow the same steps as an emergency physician. It may be abbreviated or limited, just because we don't have MRI, we don't have CT, we don't have X-ray, we don't have lab, those things we don't have. And then consider the most serious conditions associated with the patient, and it either rules them out or in, and then we create a diagnosis. So, approach to diagnosis in medicine, shortcuts and biases. So, when we talk about shortcuts, we talk about we talk about experience. Okay. Pattern recognition, features, narrow possibilities. So heuristics, okay? Heuristics is, by definition, is enabling a person to discover or learn something for themselves, okay? So just as kids learn that, hey, maybe I shouldn't do this because it's going to hurt, we learn by doing things and experience. So we learn that, hey, an MI is going to present like this. Or we learn that most patients are going to be presenting like this particular way when they have respiratory problems. So I can teach that to you, but there are some things that I can't teach you, and you're just going to have to learn on your own, such as patient assessment. I can teach you, I can give you the base knowledge, and then you have to make it your own and what works for you. It does allow us to reach a diagnosis more quickly. There are limitations of these, and we can get into a narrowed focus. We can get into confirmation bias, where we are looking at the signs and symptoms because we know that this should be what it is, or what the patient's problem is, but it doesn't necessarily line up, or it's not what the patient has. So we see what we want to see, and make a diagnosis based on that. Okay. So how can you learn to think like an experienced physician? Learn to love ambiguity. Understand the limitations of technology and people. Realize that no one strategy works for everything, and form a strong foundation of knowledge. Okay, that's why we went through anatomy and physiology. That's why we went through pathophysiology, because that is the foundation of medical knowledge. Organize the data in your head, change the way you think, learn from others, and reflect on what you have learned. Okay. Um, there have been many medics that I've worked with when I was an EMT that influence the way that I do my medicine, and the way I practice. Um, and you'll learn those things too. Okay. Um, there's things that some medics are better at, um, and there are some things that some medics are not good at. So some medics are really good at cardiology. Some kind of suck at it. Some are really good at trauma, and some just suck at trauma. Okay. So it just kind of depends on where you're at, and your learning.